It's my pleasure to be here to talk about the use of lasers in a patient population that has historically been underserved when it comes to lasers and aesthetic procedures in general. And a lot of this has to do with safety concerns, especially with first-generation lasers and devices where the risks often outweigh the benefits of these procedures. But over a couple decades of new developments in laser technology, we now are able to offer a range of safe and effective treatment options for our patients with Fitzpatrick skin types 4, 5, and 6. And that's what I'm going to talk about tonight. So if you can just give me a moment to share my screen, I'll do that. Okay. So I know we have people from all around the US and internationally, many different levels of experience with using lasers and devices, energy-based devices for skin of color. But I'm going to just start really at the beginning and give a broad overview, and then we'll talk about some specific applications, specifically of the microsecond pulse 1064. Now, when we think of the global population and we think about skin type, level of complexion, we realize very quickly that the majority of the world's population would fall within the spectrum of what we call skin of color. Here in the United States, the proportion of the population that describes itself and is projected to describe itself as belonging to any of the non-white racial ethnic groups, this proportion is projected to increase dramatically over the next few decades, such that even by the year 2044, more than half of the US population is projected to belong to any one of these non-white racial ethnic groups. And so as clinicians of various backgrounds who are involved in the aesthetic space, it becomes increasingly important for us to understand, well, how can we serve this increasingly diverse population, that is going to be, that already today and going forward, increasingly shifts to the higher Fitzpatrick skin types, and what do we need to know with respect to the best treatment options and protocols. Already today, about a third of aesthetic procedures are estimated to be performed on the various non-white racial ethnic groups in the United States. And this, of course, is projected to increase, not only because of the demographic shifts, but also because of the development of newer technologies that are applicable to a broader range of Fitzpatrick skin types. So when it comes to skin of color or higher Fitzpatrick skin types, such as 4, 5, and 6, what are the key things we need to know when thinking about lasers and energy-based devices? Well, first, there are a number of important structural and functional differences, the most obvious of which is that the more darkly compared to lightly pigmented skin, darkly pigmented skin has more epidermal melanin. The number of melanocytes does not differ between skin types, but the amount of melanin that's synthesized, how much of it is packaged into melanosomes, and how those melanosomes are distributed in the epidermis, that's what differs. The melanocytes themselves exhibit responses that are described as labile. They may they may respond to injury and inflammation with increased pigment production or decreased pigment production. The fibroblasts in the dermis also tend to be more reactive in some populations with skin of color, and this is thought to be associated with the increased tendency towards hypertrophic scars and keloids that have been observed in various populations with skin of color to a higher degree than others. So this has important therapeutic implications, of course, with the protective effect of melanin and the melanocyte lability. This contributes to variations that we see in what the leading aesthetic concerns are, and manifestations of photoaging vary between populations. We also recognize that there are higher risks of pigmentary and scarring complications in general when it comes to the spectrum of skin of color. And this in turn means that there are going to be differences in preferred treatment options and parameters for safety reasons. With respect to variations in leading aesthetic concerns, we see that when it comes to photoaging across different populations, in more richly pigmented populations, the manifestations of photoaging tend to be delayed as much as a decade or more. They tend to be less severe and can vary as far as priority. So whereas in lighter skin phototypes, peri-orbital rhytids, crow's feet, and peri-oral rhytids may be very prominent and a key concern. And this is less prevalent, less of a concern in more richly pigmented individuals, where prominent nasolabial folds and tear trough deformity and laxity in the neck may be more prominent than some of these other features seen in lighter pigmented individuals. So in other words, there is no one size fits all. There's variations across the spectrum. And at the same time, we have to recognize there's variations from at the individual levels. So we can't make broad generalizations about these very diverse populations having specific facial features over another. These are just general tendencies. It doesn't replace the individual assessment of every patient in front of us. So a recent survey that we published identified that uneven skin tone was the most frequently reported facial concern among African American women. And this is consistent with our clinical experience and studies from other patient populations of color. And on the whole, when we look at the leading aesthetic concerns in patients with skin of color, we see acne, which is both medical and aesthetic, depending on certain aspects of it and the approaches to treatment. Hyperpigmentation, as I mentioned, unwanted hair is a huge issue, and textural irregularities are some of the, in my experience, the top 4 aesthetic concerns in my patient population with skin of color, and consistent with the literature. So when thinking about approaching these patients with our lasers and other devices, we have to recognize the higher risks of pigmentary and scarring complications. And so we're constantly striking this delicate balance between the controlled injury of the cosmetic procedure and the risk of pigment alteration and scarring. If this balance is not optimized, for example, if using a suboptimal wavelength of laser for a given patient's skin type, it can result in disfiguring and long-lasting complications such as this. Even when one uses the most appropriate wavelength of laser, if the settings or the technique are not optimized, there can still be complications that are disfiguring and long-lasting, as in these examples. So every time we pick up a device, and particularly when we're treating patients of color, we have to think very carefully about, well, what pre and post-treatment precautions should I take into account? What is the most appropriate device settings for this particular patient so I can minimize the risk of pigmentary complications and worse still, scarring? And as a general rule, the parameters tend to be more conservative because of these higher risks. It's also important to understand that patient in front of you, not to make assumptions about their ancestry or how their skin is going to react. You do have to do a little bit of querying, a little bit of assessment to figure out and risk stratify. And we still don't have a perfect system for this, but the best we have is at least taking a detailed history about the patient's ancestry. That can be informative as far as predicting responses to some degree. When it comes to the Fitzpatrick skin phototype, it's inaccurate to just look at the patient and assign a number based on the exposed skin. It's far better to use the Fitzpatrick skin phototyping system the way it's intended to, which is to understand what the patient's typical response to UV radiation is. So you're going to ask the appropriate questions about tendency towards and burn in response to sun. You want to assess response to injury or inflammation using everyday examples that any patient can kind of relate to: insect bites, cuts and scrapes, acne. How likely is their skin to hyperpigment in that scenario? And one can look for examples on exam. And similarly, asking about any history of keloids or hypertrophic scars. So including this in your initial consultation is helpful. To illustrate, these three examples, these three gentlemen have similar levels of pigmentation in the exposed skin, but come from three completely different geographic backgrounds. They have completely different genetic predisposition for various outcomes, and you can make inaccurate assumptions if you just look at these individuals and think they may be all similar when they are in fact very, very different. An interesting, useful tool that's been described and recently published by Hector Leal Silva uses the contrast in terms of pigment within the palmar creases. So he's designed what is called the palmar creases pigmentation scale. And when looking at the degree of pigment within the palmar creases as compared to the surrounding palmar skin, you assign a score. And it's been observed that the higher this score or the more pigment there is in the palmar creases, perhaps the greater tendency there is for post-inflammatory hyperpigmentation. So this is something that I think deserves further investigation to be validated across diverse populations. But this is an interesting extra tool that one can incorporate right away without taking much time. Whenever you get a new device, I recommend that in addition to studying the manual that is given to you, to actually perform some test spots on a number of patients to get a feel for the typical responses with using the recommended settings. We've got to emphasize with our patients the importance of sun protection. And of course, across the various cultures within skin of color, there may be different levels of background rates of using sun protection. And in my experience, some of the complications I've had, even using safe lasers, have occurred in the context of the patient getting sun exposure and not having the adequate protection, like in this example of this gentleman who hyperpigmented after a fractional, non-ablative fractional laser procedure, but admitted to being outdoors for many hours on a sunny day. So I'm going to focus on the rest of the presentation on maximizing safety in Fitzpatrick skin types 4 through 6 through the use of an optimal wavelength and thinking about settings. And specifically, I'm going to be talking about the use of the 650 microsecond pulsed Nd:YAG laser and its advantages and broad applications in skin of color. So why this 1064 wavelength that we keep talking about? Every time we talk about skin of color, we talk about this 1064. Why? Well, we know that the longer the wavelength, the deeper the penetration. And because we have a competing chromophore in melanin in the epidermis, and the targets for most of the things that we're trying to do are down in the dermis, such as with respect to laser hair removal, where we're trying to target the melanin in the hair shaft, and then the heat transfers to the follicular stem cells. And so we want to minimize absorption up in the epidermis and maximize absorption down in our target. And we can do that with a longer wavelength, like the 1064. So 1064 is in the near infrared spectrum. You can see where it fits along the melanin absorption curve. There's also some absorption from water and hemoglobin. When looking at the literature and looking at rates of complications from the different lasers that would be used, in this case, this is lasers used for hair removal, we see the lowest complication rates in skin of color with the long pulse 1064. Now, traditionally, when the long pulse 1064 was used in skin of color, for example, for hair removal, devices with pulse durations in the millisecond range were used, and this would require effective epidermal cooling to minimize injury to the epidermis, unintended injury to the epidermis. So cooling in the form of contact cooling or cryogen cooling. But it turns out, using a shorter pulse in the microsecond range, specifically 650 microseconds, we're able to deliver a very short pulse that doesn't result in heating of the epidermis and gets that, heats up the intended target and allows us to use decent, effective fluences without the downside of epidermal absorption. And this is thought to occur because 650 microseconds is less than the thermal relaxation time of skin tissue, which is approximately 700 microseconds. So I'm going to talk about how microsecond pulsed Nd:YAG can be used broadly for addressing many of the aesthetic concerns in skin of color, starting with laser hair removal, which is where I use it the most, which is such an important concern among populations with skin of color. So historically, using devices like this that were 800, 810 nanometer diode lasers, still useful, especially for lighter brown complexions. But once you get into deeply pigmented skin types, if you push the fluences up, you wind up with complications like this. So this is where the long pulse 1064 Nd:YAG has found its place. But with the long pulse, again, devices like this that require contact cooling, as in this example, or cryogen spray cooling, as in this example, which has resulted in this not frequent, but it's a complication that can occur, this crescent-shaped hyperpigmentation if the cryogen spray is not optimized. So moving from those traditional approaches, we now have using microsecond pulsed, or the 0.65 millisecond pulsed Nd:YAG laser, which has been studied for hair removal. There are a couple published studies showing its safety and efficacy in patients with higher Fitzpatrick skin types, showing very satisfactory long-term hair reduction after a series of treatments. These are a couple of studies here. And overall, high satisfaction and safety with. Another observation from using this is that in addition to not having any contact with the patient's skin, which is quite advantageous, no gels and no need to think about cryogen spray, it also tends to be very well tolerated to patients. Patients report this to be very minimally painful, especially my patients who've tried both ways, the millisecond range versus the microsecond pulse Nd:YAG. They do notice a difference. So these are a range of examples, and this is what it looks like. As you can see, the laser is held away from the patient's skin, no contact, and pulses are delivered. So recommended settings, this device has a 6 millimeter collimated lens, and at the 650 microsecond pulse duration with the 1064 wavelength. We use fluences typically in the range of 11 to 28 joules per centimeter squared. I generally start at 14 joules per centimeter squared and then work my way up with subsequent treatments. Particularly as the hairs become finer and more sparse, I can increase the fluence accordingly. This also has applications in terms of photo rejuvenation. There is absorption by water, and so this is absolutely safe and applicable for just global photo rejuvenation in all skin types. Typically, patients will report an increase in radiance. They might notice that there's sort of a smoother texture to their skin, even reduced pore size. It's a very easy procedure, very safe and high satisfaction. Typical fluences used are shown here, 11 to 18 joules per centimeter squared. And in this case, you do 4 to 6 passes on the cheeks, fewer in other parts of the face, and 3 to 4 treatments approximately 1 month apart is what's done. Now, what's very exciting is the applications of this technology to treating a real core issue in skin of color, and that's melasma, postinflammatory hyperpigmentation. Briefly, melasma is something that we all recognize here, often symmetrical brown patches on the cheeks, The edges of these patches can sometimes be somewhat have a feathered-like appearance. The nose is often involved, the forehead, the upper lip. And while it's predominantly in women, we also see it in men less frequently, but it does happen. And histologically, we know that in lesional skin, there's increased melanin deposition in the epidermis, but also in most cases, also some involvement in the dermis. There's hyperfunctional melanocytes in lesional skin, which means larger, more prominent dendrites in the melanocytes, increased melanosomes, and we can see these melanosomes in the dermis as you come over here in this image. Meanwhile, perilesional skin is lacking those features. But beyond the pigment, there is also a vascular component which can be observed clinically, but also histologically. And so we see that in lesional skin, shown on the right, we see evidence of increased vascularity within the melasma lesion, and perilesionally, we don't see that same increased vascularity. So putting it all together in terms of what's the typical approach to melasma, we know that we still use, we depend on topical bleaching agents, hydroquinone 4% and other concentrations being considered the gold standard, especially the modified Kligman-Willis formula, the triple combination of hydroquinone, a retinoid, and a corticosteroid in fixed combination. But there are limits to hydroquinone in that it can cause irritant dermatitis. The long-term use is associated with exogenous ochronosis. And so we typically turn to non-hydroquinone agents, including azelaic acid, topical retinoids, and a range of cosmeceuticals, a growing list of cosmeceuticals that have unique ingredients beyond hydroquinone that can be used sequentially or concurrently, and to enhance the efficacy, because many times just topical therapy alone, you reach a certain plateau where you're not getting any further responses. And this is where we turn to our in-office procedures, including superficial chemical peels, lasers with caution, and this is where the microsecond pulse Nd:YAG is one option, treatments such as tranexamic acid or oral polypodium leukotomus as an adjunct can be considered. All the while, we want broad spectrum sunscreen, including tint, to protect against visible light. So what lasers and light-based devices can be used for hyperpigmentation in skin of color, including melasma? Well, we can use an IPL, but there are considerable risks beyond Fitzpatrick skin type 4. So in my opinion, I don't think it's a good application for skin types 5 and 6. We have non-ablative fractional lasers. They can be very useful, including the 1927 nanometer diode. Low fluence Q-switch Nd:YAG 1064 is widely used around the world, especially in Asia. Picosecond laser, increasing experience with that, with diffractive lens array. But something that may not be as well known and is really emerging is the use of the 650 microsecond pulsed Nd:YAG, and we'll talk about how that fits. When we look at the literature, the strongest evidence in terms of the number and quality of studies that are out there would be with the Q-switched Nd:YAG laser. Now, despite that strong evidence and its wide use, especially in Asia, where it's used, often referred to as laser toning, and it uses photoacoustic and photothermolytic effects to destroy the melanosomes. While it can be very effective, you have to be aware that there's this disfiguring complication of punctate leukoderma, which can occur with this technology. And so there are certainly advantages to using not Q-switched Nd:YAG, but microsecond pulsed Nd:YAG for melasma, where we don't have this risk of punctate leukoderma, and we can, based on the absorption of 1064 wavelength, we can get some absorption by melanin and also hemoglobin, given the vascular component of melasma. This might be very, very important in terms of maximizing the outcomes. recent paper published, they were treated with the 650 microsecond pulsed Nd:YAG. The settings used are shown here. 6 out of 10 of these patients used this laser as monotherapy. The other 4 had combination with oral or topical agents. And 1 patient had 3 prior treatments with a non-ablative fractional laser. All the patients here reported improvement and were observed to have improvement in melasma as early as 4 weeks after their first treatment, and had continued improvement with multiple treatments. Follow-up, which is always important in this condition where there's a tendency for relapse, was 4 to 6 months after the final laser treatment session, and there were no cases of rebound or worsening in this study. Obviously, longer follow-up would be even better, but this is good preliminary evidence of a longer-term result. So this is an example of one of the successes from this study, from this series, using the 650 microsecond pulse duration 1064 Nd:YAG in combination with other bleaching agents in this particular case. This is another small case series, actually, using the same technology, 650 microsecond pulsed Nd:YAG, in combination with a topical bleaching agent called cysteamine. This is 5% cysteamine, used for 15-minute short contact in combination with the laser, and showing a pretty favorable aesthetic response from that. And here are some other before and afters. This from Dr. Cheryl Burgess, and this from Dr. Wendy Roberts, showing very favorable results as part of a combination treatment. So in short, with the microsecond pulsed Nd:YAG, we are seeing broader applications moving from hair removal to hyperpigmentation, including melasma. What about PIH? Now, post-inflammatory hyperpigmentation is exceedingly common. It's even more common than melasma in patients of color. We know that this is a sequela of any inflammatory condition of the skin, especially acne is one of the #1 causes of it. We can see epidermal hyperpigmentation as well as melanophages in the papillary dermis. Topical therapies are often insufficient as far as getting the types of outcomes that our patients are looking for. And so we turn to in-office procedures, be them peels or lasers, to try to increase efficacy. And there is growing experience using the 650 microsecond pulsed Nd:YAG laser as an adjunct to treating this. And this is shown in this recent paper in the JDD. Here are some examples of PIH responses after several treatments with the microsecond pulsed Nd:YAG. And this one here, this one is in combination with a chemical peel. Recommended settings when treating hyperpigmentation disorders like melasma and PIH. Conservative fluences, 11 to 21 joules per centimeter squared. Typically do 5 to 6 passes per treatment, and 3 to 5 treatments approximately 4 weeks apart are required. And so I was explaining that, beyond laser hair removal, treating hyperpigmentation, photorejuvenation, another evolving application of using the 1064 Nd:YAG laser at the microsecond pulse duration is treating acne. It can be used as a primary treatment for acne or as an adjunctive treatment for acne. We all have patients who might benefit from oral antibiotics, oral isotretinoin, topical retinoids, et cetera. But for various reasons, they may either not be great candidates for these therapies or are not interested in being on prescription medication and are looking for alternatives. And so this is now another alternative that we could offer them. So why would this work in acne? Well, the proposed mechanisms will have to do with the absorption by hemoglobin and by water. And as a result, when treating the skin at this wavelength, there are some downstream consequences that are beneficial to the overall management of acne, such as destruction of C. acnes, reduction of some of the post-inflammatory erythema that we see around acne lesions. We can see some stimulation of neocollagenesis, which downstream will help with acne scarring. So these are some of the proposed mechanisms. And here are some before and afters that have been submitted by various practitioners using this technology for acne, either as adjunctive or standalone. And a recent publication by Michael Gold and colleagues looks at the application of the 650 microsecond 1064 Nd:YAG as an adjunct to using isotretinoin. In this case, these patients were treated with low dose isotretinoin coupled with this laser, and you can see the before and afters that are quite impressive shown here. And this paper tells us a couple things. Number one, given that there are still some unanswered questions and concerns in general because of historical contraindications of using certain lasers and cosmetic procedures while on isotretinoin, this shows us that it's absolutely safe to use this wavelength and this approach while patients are on isotretinoin. To what extent this is offering greater efficacy than isotretinoin alone. This was not a comparative study, but hopefully in the future we'll see one that has that comparison, but excellent outcomes nonetheless. Recommended settings when treating acne. It's an interesting approach. Again, we're using the 6mm collimated lens here and the 650 microsecond pulse duration again. But here's the difference. So we're doing things in two steps here. You treat regionally first with 3 passes of non-overlapping but closely spaced pulses across the entire affected area. The range of frequencies are shown conservative for skin of color. And the second step is to then treat individual lesions with 3 to 6 pulses per lesion, depending on size, again, using conservative fluences for skin of color shown there. So in short, I hope that in tonight's webinar, I've shared with you some extra insights into the use of lasers to treat a broad range of aesthetic concerns in skin of color. Despite the higher risks of pigmentation issues and scarring that can occur in general, we now have technologies such as the 1064 Nd:YAG, 650 microsecond pulse duration that can safely and effectively address a whole range of aesthetic concerns in skin of color. And I hope that this has been helpful for you and that you'll be able to apply some of this for your patients. Thank you very much. And I'm happy to take any questions in the time that remains.
All right, thanks, Dr. Alexis. So we have a number of questions here in general. I've been trying to answer some as they come along, but let me see what stands out to you.
Right. So I see, I'm just seeing some comments coming through here. I see one comment. I would love to know about hidradenitis suppurativa as well. I think that's a great question. We do know there is some experience in general of using the 1064 Nd:YAG for hair reduction in the treatment of patients with HS by injuring the follicle, removing the hair. There can be improvement in HS, and I found it to be a useful adjunct for some HS patients. So I do think that there's an application here, and I think this is an area that will be studied further, and so we should see some data down the road. Sean, did you want to ask me any questions, moderate this, or would you like me to just pick?
So I think there's a couple on here that have come through. Obviously, we have a lot of different questions about specific applications, dark circles under the eyes. How do you treat scars? One of the most common ones we get, is with pigmentation for darker skin, as you had gone over. How do we address that confidently to make sure that we're getting the right results without any sort of complications.
So is the question, how do we ensure that we minimize complications when treating pigmentary disorders like melasma?
Melasma, PIH, sun damage. Yeah.
Yeah, I'm going to use melasma as an example because I think that is one of the most difficult pigmentary disorders that we have to treat. In that, you know, if you look at the literature, there's just countless devices that have been used for melasma. But the problem is that while they may be useful in some patients for short term, there's often relapses, rebounds, even worsening of the melasma, and in some cases, dyspigmentation that is worse than the original melasma, depending on the device that's used. So I've been impressed by the safety of using this approach of microsecond pulsed Nd:YAG for treating melasma. In terms of actual data to support its efficacy, I think we need more studies. I'm reassured by the study that I showed, the small study of 10 patients from Dr. Ortiz, excellent responses there. But in terms of optimizing the best, getting the best outcomes, I think we need more studies. From a safety perspective, though, with this approach, punctate leukoderma is not a significant risk at the fluences that one would use, and that's lower fluences. You've got to be conservative with the fluences with melasma. The adjunctive skincare is so key too. Obviously, the protection against sun, UV, visible light protection with tinted sunscreens, and adjunctive use of other agents to reduce pigmentation. So hope that answers your question.
Excellent, thank you. It's very, very common we are asked that. Another one that comes up a lot of the time, so we talk about the Fitzpatrick skin types. In terms of African, African-American, Hispanic, Latin, Indian skin, Mediterranean skin, what are we trying to look for in terms of the safety in the settings that we're accomplishing? Yeah,
so it's a great question, because when we look at the literature in lasers in general, and we hone in on skin of color, a lot of the experience comes from Asian populations. And so we got pretty good data on skin type 3, lighter skin type 4s. But once we start getting to 5s and 6s, it becomes a wide open space with respect to data. So when it comes to, if your population is predominantly of African descent with Fitzpatrick skin types 5s and 6s, I think you can confidently use the Nd:YAG 1064, including the microsecond pulse duration, as long, again, using lower fluences. So I typically start, it really depends on what it is that I'm treating, but let's say hair removal, which is the number one thing that I treat with this approach. I'll start at 14 joules per centimeter squared, and I'll only increase after subsequent treatments after I've confirmed that the patient has tolerated this well, and that there's much less target, so much less absorption by the chromophore melanin in the hair shaft. So as you get finer hairs, more sparsely distributed hairs, you can push the fluences up for greater efficacy, but always start low and work up.
Thank you for that. A couple more questions here. We have a number that are speaking to, discontinue retinoids, retinal protocols. Can you combine those? Combination therapy just in general, depending on the condition that we're working on. A lot of the questions are asking about acne, pigmentation with tranexamic acid. Do you have some favorite protocols for acne, skin rejuvenation, melasma that you typically use combination therapy for, if needed?
Sure. So the first question was about, the first part of the question was about retinoids. We frequently see in laser protocols, just sort of generic laser protocols, stop retinoid before the procedure. When using the 1064 Nd:YAG, I don't find a need for stopping a retinoid. I certainly stop a retinoid before a chemical peel. 7 days before a chemical peel in Skin of Color, I'm going to have the patient stop it. With other procedures, it is epidermis is targeted. Okay, I'm going to stop the retinoid. But when one thinks of the mechanisms and the target with the 1064 wavelength, I don't think that there's any concern about increasing risk with having a retinoid on board. So I keep the retinoid on board. I don't stop it in this particular case, the 1064 Nd:YAG. As far as other combinations, as I described with melasma, the approach to melasma, I'll use hydroquinone-based and non-hydroquinone-based combinations, such as the triple combination hydroquinone formula and non-hydroquinone agents such as, and I won't mention any brand names, but cysteamine is one. Cosmeceuticals that contain topical tranexamic acid, contain niacinamide, contain kojic acid, other well-known skin lightening ingredients, azelaic acid. These would be some of my typical non-hydroquinone agents that I'd combine with procedures to get the best outcomes.
Excellent, thank you. Very good pearls on that. One question that we do get as a company, when we're talking about the 650 microsecond pulse, we talk about its efficacy combined with the safety and comfort. So why would it be different than a longer pulse 1064? You're not able to do multiple passes where you can do multiple passes here.
I see. So why is it that we can do multiple passes with the microsecond pulsed Nd:YAG, whereas with traditional millisecond pulse durations, we don't do multiple passes? Is that the essence of the?
That's the essence, yeah.
Yeah. Okay. Great question. And it has to do again with the estimated thermal relaxation time of the skin in general. Like studies that have looked at what's the thermal relaxation time of the skin have found it to be between 700 microseconds to 1,000 microseconds. And so by falling below the thermal relaxation time of the skin, we're able to deliver this ultra short pulse that doesn't result in any significant heating of the epidermis and injury to the epidermal melanin, but we are able to get to targets, deeper targets, like the melanin in the inferior part of the hair follicle, well, in the hair shaft first, and then it dissipates to the hair follicle. So it's because of that ultra short pulse duration that's less than the thermal relaxation time of the skin. So with that extra safety, we can go back and deliver an additional pulse. So when I do laser hair removal, for example, I'll treat the whole region first, one pulse closely, one pulse after the other with minimal to no overlap. But then I'll go back and visualize any persistent hairs and deliver a second pulse or two to persistent hairs, and that leads to great outcomes. And I've not seen complications from this approach using lower fluences. Again, as safe as the wavelength is, you still have to be think about what fluences you're using for the given patient. So,
yeah, absolutely. I think that's a good point too. And that actually killed two birds with one stone, as we had a bunch of people asking about multiple passes for hair removal as well, altogether. And so with respect to the time, I wanted to leave off with one more question for you. So as we discussed in your biography, you are well known for your research and education on this topic. So two parts with that. One, how can people follow along with you for kind of further their education for what you're already doing? And two, how do you go about educating outside of the medical community? How do you educate your patient community about topics like lasers and aesthetics for skin of color? Are there any tips and tricks that you can relate to the audience?
Yeah, thank you for that question. So just when it comes to education from us, the the clinicians who are delivering the care. There are multiple sources of good education related to skin of color, including the Skin of Color Society, a Skin of Color CME meeting called Skin of Color Update. There are increasingly textbooks or chapters within textbooks that focus specifically on the nuances of treating skin of color. But the question about treating or educating our patients is a great one. And I don't have the perfect answer as far as how best do we educate our patients, because there's so much misinformation, as I'm sure most of us can appreciate. There's just so much misinformation about using lasers and skin color. Every single day, I'm faced with a patient who tells me, "Oh, but I thought we couldn't use lasers and skin of color. I read that they're just not safe, and now you're offering a laser as a treatment. I don't understand. I thought they weren't safe." So these misconceptions are are widely held, and they were true with a certain set of devices. But we now have better technologies that are safe for the range of Fitzpatrick types that we have. So how do we educate the community? I think it's a work in progress. We're still not there yet, and I think that some of our efforts, which include putting stuff out on social media, traditional media, using big websites like the Skin of Color Society to educate the community. This is what we have now, but I think we can do a better job of educating the general public about this.
Yeah, we know that's an ongoing thing, and that's one of the, obviously why we're holding this as well to our customers and people following us along as well. But I appreciate that answer, and I think that you are very much spot on with that. So, okay, as I mentioned, we are coming up to our time here. So, Dr. Alexis, thank you so much for the presentation. We have a lot more questions to answer, but we will follow up with everyone at tomorrow, the next day, as we go along here. So. Thank you very much. I'm not sure if you have any parting statements for us, but again, excellent presentation.
Thank you very much. I guess I'll just close with a follow-up to that last question about how do we educate our patients about the use of lasers for addressing their concerns. It's very powerful to be able to show before and after images in patients that look like the patient that's in front of us. So being able to have those diverse before and afters to share with your patient, and that gives them a great deal of confidence in considering lasers like this for their treatment. And thankfully, such before and afters is quite an impressive collection available that Aerolase has, and so that's helpful. And then there's also what's been published in the literature. So doing your PubMed search and pulling up some of the articles, and you'll see some good before and afters that you can share with patients too. So thank you all for your attention, and hope to see you in person at future meetings.
Excellent. Thank you so much, Andrew. And everyone, have a great night. We'll be in touch. Bye-bye.
Bye-bye.